You are officially invited. Yes, you're invited to join us in Fertility Awareness Mastery Live. This is my 10-week group coaching program designed to help you gain confidence using fertility awareness. Whether you're actively avoiding pregnancy or looking to optimize your cycles for conception, we have a spot for you. We start the first week of May. Are you ready to jump in? Head over to fertilityfriday.com/fam to register today. That's fertilityfriday.com/FAM. This is the Fertility Friday podcast, episode number 411. Welcome to the Fertility Friday podcast, your source for information about the fertility awareness method and all things fertility. I'm your host, Lisa Hendrickson-Jack. I'm the author of The Fifth Vital Sign and the Fertility Awareness Mastery Charting Journal. I'm a certified fertility awareness educator and holistic reproductive health practitioner with nearly 20 years of experience teaching women to connect to their fifth vital sign through menstrual cycle charting, balancing hormonal health, and optimizing the menstrual cycle without hormones. I'm outspoken about hormonal birth control and its impact on fertility and overall health because you have the right to know how your body works and how artificial hormones disrupt that natural process. I teach women's health professionals how to utilize the menstrual cycle as a vital sign in their practices, and I host live coaching programs to help you achieve optimal fertility and health, because it's important to have healthy menstrual cycles regardless of whether or not you want to have babies. I'm also a wife and mother of 2 beautiful boys. I know, I'm a busy girl, but I managed to fit it all in. This podcast is designed to empower you to take full control of your cycles, your fertility, and your overall health. And I'm so excited that you're here with me today. Today, I'm excited to share a brand new episode. I'm sharing my interview with Dr. Nora Pope and Dr. Jessica Liu. And in today's episode, we're talking about progesterone, as always, but we're also talking about seed cycling. And Dr. Jessica Liu has some really interesting information to share about it and even some research about why it works. So before we jump in, I'll just tell you a little bit about Nora and Jessica. Nora Pope is a retired naturopathic doctor and Creighton model fertility care practitioner with a private practice in Toronto up until 2019. She is the creator of cycle charting, the key to fertility, and together with Dr. Jessica Liu, they have created the Fertility CE continuing education program for medical health professionals, including naturopaths, doctors, and everything in between. Dr. Jessica Liu is a naturopathic doctor with over 16 years of expertise and clinical excellence in the field of fertility, women's health, and pregnancy care. With an extensive background in natural reproductive medicine, Dr. Liu has helped hundreds of families conceive healthy babies, both naturally and with assisted reproductive technologies. Her program, Creating Vibrant Fertility, has a particular focus in supporting women to move through the emotional trauma of sub-fertility and pregnancy loss in order to awaken their optimal fertility potential. She is published in Seed Science Research and has lectured as a speaker at the Canadian Fertility Show. And without further ado, let's go ahead and jump into today's episode. And I'm really excited to be here once again with Nora Pope and Dr. Jessica Liu. Welcome to the show.
Thank you. So excited, Lisa.
Good to see you again, Lisa. It's been far too long.
Yes, I know. I think the last time we saw each other, you had been presenters for my fan practitioners, which was incredible.
That was fun. So much fun. Great group.
Yes, and so informative, and they loved it. So we're excited to have you back.
Thank you.
I mean, today we're going to be talking about pharmaceuticals, progesterone, their use in the cycle. So lots of really great topics to jump into today. And I'm just kind of actually looking at some of my notes that I have for a call. And I think a good place to start, which is kind of not like, well, it'll get us into the pharmaceuticals. But one of the questions there, could you talk a little bit about infections and how they're related to miscarriage? I mean, let's just jump right in.
Sure. Yeah, no, it's, we offer a 6-hour course for healthcare professionals. And in one of the sections on the pharmaceutical section, we want to talk about sort of the hidden causes of miscarriage or preterm birth or obstetrical emergencies that are below the radar. And low-grade chronic infections of the lining of the endometrium can cause complications like preterm birth, like miscarriage. And they often go undiagnosed because people aren't really taught about charting. So Lisa, as you know, when you teach a woman cycle charting, it's not just about her hormones, it's about her overall health. And it's a fifth vital sign, and it's a reflection of her systemic, situation. And so what's very common what's more popular in the sort of the pop culture is, that egg white discharge, that's your fertile mucus. So this is a good start, but there's all kinds of discharges, and there's a lot of non-fertile discharges. And one of them is called wet without lubrication, or 2W in the Creighton model world. And this is like a drip, 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 drip. And if a client comes to you and says, I'm always needing pads, I'm always wet, I'm always dripping, that drippy, white, wet, clear discharge can be an occult infection. And that can hinder a healthy pregnancy. And so antibiotics given in the ER, if a woman's coming into the ER and she has premature contractions and the ultrasound reveals that the baby is still quite young, they don't do anything else. And it'd be nice if they maybe consider progesterone, but the progesterone's not going to work as well if she has an infection. So maybe do a swab, ask about her discharge, and give her a broad-based antibiotic, and that will halt the contractions, whereas anti-contraction drugs or tocolytic drugs won't work. It can really help save a life. It's just knowing about the signs and presentations of what is a low-grade infection jeopardizing a full-term pregnancy.
And you mentioned the infection potentially of the endometrial lining. Is that something that would show up in a similar way with the wet discharge, or does that show up in a different way?
Well, that's a good question. So types of infections that you'll notice on charting is 2W can be one of them. Another one is the red spotting before period, red spotting after period. And that can be a cause of just chronically low hormones, and not necessarily, the initial insult wasn't an infection. The initial insult was low hormones. And what's happening is that you're not building up a healthy lining of the endometrium. And then you're not having a proper shedding of the endometrium during your period because you've had low hormones, and it's not giving you those clear demarcation lines of, okay, my cycle's charting today, my cycle's starting today, and my cycle's ending this day. So what happens is you had low levels of hormones, and then the lining of the uterus is not healthy, and it starts breaking down, and you have that premenstrual brown bleeding or premenstrual spotting. And what happens is because it's friable and not well formed, it becomes a vulnerable tissue, and it becomes vulnerable to opportunistic infections. And then it can lead into endometritis. And so spotting needs to be monitored as well. That's another powerful tool of cycle charting. And so there are many signs, but cycle charting is of course our roadmap. And Jessica Liu and I are just very, very passionate about getting this information out to clients and to practitioners. So we do cover antibiotics in our course because it can save a life, but also it can really restore fertility. And Jessica, remember we were talking about the several classes of antibiotics? There's ones for infection, but then there's actually an estrogen enhancer in a class of antibiotics.
Yeah. So one of the things you have to think about now, I'm happy to see that the literature is catching up, is that there's this crazy association between the gut microbiome and our hormones. So this whole idea of the estrobolome now, so how our microbes inherent in our system can actually impact estrogen metabolism. So there are say pathogenic bacteria that live all the time in our gut that can decrease or increase the metabolism of estrogen out of our body. And so one of the things that we've seen in some of the cases we looked at, so interesting, is that a course of antibiotics, when all else fails, they threw in an antibiotic for an infertile woman. And what that ended up doing was actually improving her estrogen retention in her body, because the antibiotic kind of slowed down the liver metabolism of estrogen. And that ended up helping to grow a stronger egg and improve fertility. So it's really wild.
And increase cervical fluid too. So
exactly.
It extended her fertility window. So it's so interesting. You do this lateral move to help a woman augment her hormones, and it can also restore fertility. And so antibiotics have multiple applications in the restoration of fertility. Very, very interesting. Yeah. So we, of course, we're trained as naturopathic doctors, and of course we want to restore health with acupuncture and botanicals and nutrition and diet and lifestyle. And we're big proponents of progesterone. But when drugs are used in a low dose fashion, and a very strategic fashion, very targeted fashion, They're very restorative, and I would say very naturopathic.
Well, I have a couple of follow-up questions because I feel like at this point I'm like in the mind of at least most of my listeners or some of them. So I just want to touch on two things. The first thing, and then I'll go on to the second thing after, is the spotting. So because someone's listening and thinking I have spotting as an educator who's, working with clients all the time. A lot of women have spotting. A lot of women have spotting before their periods. A lot of women have spotting after their periods. So is there, again, for the listener who's like, I have spotting, does that mean I have an, endometrial infection? And so I think one of the things you mentioned is that the spotting obviously is indicative in most cases of low hormones. If you have optimal hormone production during that luteal phase, you're not going to see a bunch of days of spotting. But is there something else to look for so that every woman who has the spotting isn't like thinking that she automatically has an infection?
An occult infection. That's a good point. I think it has to be a diagnosis of exclusion to an extent, right? Like you want to follow up, obviously optimizing hormone levels and then seeing if there is a change. Does optimizing progesterone specifically on, let's say, peak day plus 3 to 12, that's physiologically where we want to hit that range, and you're doing that for a few cycles, does that clean up the spotting? Does it clean up the menstrual cramping? Does it clean up the PMS symptoms perhaps, or modulate those? And if you've been doing that for a while and it changes things, great, we're on the right track. And if it doesn't and you're still scratching your head, there may be a history of multiple use of antibiotics, possibly disrupting. Has she had a history of E. coli UTIs? Is she prone to vaginal yeast infections, vaginosis? Has there ever been a history of vaginal discharge that's looked a bit off? Those are questions that I have that maybe lead you down that path. It's not necessarily an automatic thing because occult means hidden, right? It means it's not obvious. So obviously you want to rule out the obvious things. If you have flagrant, rampant candida happening, then obviously treat that, right? Clean up the terrain. Occult is where we want to start putting on our hats and going, could there be something here? Right? Because there's actually many microbes that can cause dysfunctional uterine bleeding, not just one. You could have group B strep, you could have enterococcus, which is a fecal bacteria, you could have E. coli, all kinds, right? And they're not necessarily going to zero in on that right off the bat. They're going to rule out the obvious chlamydia, Gardnerella, yeast, they're going to deal with those first. In some of my fertility patients, ureaplasma, mycoplasma, sometimes completely asymptomatic. Sometimes there's no discharge to pin it to, right? So this is where you sort of like rule out the stuff that's obvious first and then start thinking if it still persists and there's no other answer for it that's reasonable. You've ruled out endometriosis, you've ruled out PCOS, maybe look at occult infection then.
That's really helpful. Yeah, because I guess it gives the context because it's such a common issue. And then, so I guess I have three questions. So the other question, question two is, so in order to identify something like that, are you saying that, a typical, like if you go in and you ask for a swab and a culture, is that something that would be identified at that stage just by kind of one of those typical vaginal swabs, or would identifying a uterine infection require additional testing?
It would. I think a vaginal swab can give you a clue, but it's not the full picture. I have a patient right now. She's going through a fertility treatment cycle, and they've caught endometritis that was never found before, and that was only found recently on a biopsy. Interestingly, there's a new labs that are coming out. I'm not going to say which one, but there are labs, if you look into it, that are actually doing menstrual blood cultures, which is a much more direct view of what that sloughing, the cells, what's growing in that milieu, that terrain. That
is that a thing that you could ask your doctor to do?
You can. There is one lab in Canada, I think, that outsources it to a lab in Europe that is doing that. And any doctor can requisition. It's a simple menstrual blood sample. You ship it off and they come back to you with a whole microbe view of what's growing in there. It's quite brilliant, actually.
Fascinating. So then last question, and then we can, move on. So about the antibiotics, because of course, a lot of my listeners would be familiar with potentially the link between overuse of antibiotics and the disruption of the gut microbiome. So maybe share with us a little bit about then how it can be used and in a positive way Because it's really interesting what you're saying, that it could potentially stop the contractions, lengthen the duration of gestation.
So our, what we're trying to help couples either postpone or achieve pregnancy. When they've achieved pregnancy, have a full-term pregnancy. So if women are coming to the ER in Canada, it's woefully inadequate what's helping them. They're just given tocolytic therapy, so anti-contraction therapy, and they're given an ultrasound, and that's it. So we advocate that they should be tested for progesterone, but you should rule out infection as well, because even if you give progesterone in a wonderful, bright future, it will be less effective if you have an infection as well, because it's the infection that's causing the disruption in the lining of the uterus, which is bringing on the contractions. So it's a two-pronged effect, but definitely progesterone is getting better press in terms of preventing miscarriage in the ER. And we're talking about antibiotics as well. And it'd be nice to get more ER doctors and nurses on board. Some are, but that's sort of one dramatic scenario. And chances are that woman had 2W. She had that wet without lubrication discharge, or she had spotting. So this is you have to ask your clients, have they ever had a miscarriage before? I think that's one question part of the workup. And was the spotting before or after their period? Have they had their hormones tested properly on peak +7? Were the hormones high or low? Have they had their estrogen tested on peak -3 or 5 or 2? Have they had a follicular ultrasound done during their white flow days? What's the size of the follicle? Ideally, you want to grow to about 2 centimeters. Is it smaller than that? Then that's going to also indicate low hormones. So there's a whole kaleidoscope of questions and features to help you point the person in the right direction, whether or not they need antibiotics.
I had a patient who actually had suffered now it would be considered stillborn because she lost the baby at 21 weeks. And they couldn't find anything. They had no explanation for her. Progesterone was not tested. Nothing was wrong with her cervix, just spontaneous delivery. She remembers asking the doctor about her discharge, that it seemed irritated, it was a bit smelly, and nothing was even looked at. No culture done, nothing. It was just brushed off. It happened again in her second pregnancy. She's actually in it right now. And we treated it. We treated it right away. And I had her go for a culture. Nothing came of the culture, but she did notice that discharge resolved after treatment. And she's okay. Everything's good. We're monitoring progesterone. So yeah, I mean, it sometimes can be just making sure that if you had an inkling of it before pregnancy, for sure you want to be looking for in pregnancy. Don't forget that might be a low-grade thing going on in the background still.
So I think there's a couple of things that are kind of like, one thing is that this kind of stuff is in many ways for the average woman specific to having some degree of understanding of her cycle and what's normal and what's not. And so with the cycle charting, if you are, and many women do chart, but cervical fluid is not something that's necessarily taught in detail in every method of charting. So there are plenty of women who chart their cycles, but if you go online to a Facebook group or to websites where they just showcase pictures and pictures and pictures of mucus, I had a conversation actually with one of my colleagues about this because she was showing pictures on this website, but you have to have context. Plenty of people have mucuses, they're not healthy. And you're just looking at it and thinking, oh, it's totally normal to have this gunky yellow stuff. And no, it's not. And so I think that part of it is really important. And then the other aspect of it that can be challenging for women listening who want to then, you say, okay, I should have had, for anyone who doesn't know, when Nora and Jessica are talking about peak +7 or peak +4, peak -3, peak day would be the last day of your clear, stretchy cervical fluid, which is in line with ovulation and a healthy cycle. So within a couple of days usually. And so this is a very good marker of when we should do these types of tests based on the cycle. And I know you're going to talk a little bit more about that. But many women who are going to their regular physicians who are not necessarily trained in the same way that the two of you are trained wouldn't necessarily automatically be doing it that way. Maybe you could just talk a little bit about that, especially for the women who are listening, who are kind of like rapidly taking notes and kind of like, why didn't my doctor do that? Maybe you could let us know why they didn't.
Well, this is so easy. Dear listeners, please work with Lisa and do some cycle charting. And okay, so here, I'll give you some good news. It seems daunting to learn about your cycle, but dear listener, I promise you, if you invest 90 days or about 3 cycles, this is what you're going to see. You're going to see patterns that emerge. You're going to see X number of bleed days. We call them white flow at our company, continuing education. So you can have X number of red flow days. Ideally, you want 5 because we believe in the rule of 5. 5 means you have healthy hormones from the previous cycle. Then you have a variable number of dry days. And then you're going to have 5 days of white flow. And that shows that your follicle is growing. And ideally, it's growing from that little follicle up to 2 centimeters. And that growing follicle is pumping out estrogen in the blood. And it travels to the cervical crypts, to the cervix, and turns on that wonderful cervical fluid production. And we call that white flow because it's media friendly. And we want to see Lisa on CBC and CTV and Global talk about this. So red flow, white flow, nice language. And then when the white flow ends, that's your peak day. And that correlates to maybe peak estrogen day. And that's the last day of estrogen activity. And then after that, you want anywhere from 10 to 15 days before your next cycle. So we call that rule of 5 again, 5 days times 2 or 5 days times 3. And that rule of 5, you want to see emerge. You're going to want to look at the patterns for 3 months of cycle charting with Lisa. And then you're going to say, okay, well, I have 3 days of red flow, and I have 4 days of red flow, then I have 5 days of red flow. And in this cycle, I have 3 days, 4 days, and 4 days. And then my post-peak phase is, it's about 11 days, 12 days, 13 days. So you're going to getting a sense of the patterns in your cycle. And then when you've identified your peak day, you're going to know that you want to test your hormones, estrogen and progesterone on peak +7. And then when you're told to get an ultrasound series, a lot of doctors say, go on cycle day 9. And we say at FCE, no, go on your white flow days. So when your white flow starts, it could be cycle day 12. It could be cycle day 8. So go and use your cycle chart as your roadmap to time your blood tests and time your ultrasounds. So you go in on your white flow days, you look at how your follicle is growing, and then you want to see it rupture, and then you want to go in one more time to see it shrink into that yellow body or corpus luteum. And that's the power of cycle charting. So if you have more than 5 days of red flow, if you have that drip, 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 spot, 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 maybe you want to consider getting your hormones monitored. If you have 1 day of white flow, you want to look at the stress in your life. Or do you have some kind of hypothalamic dysfunction, which is not syncing up your hormones to produce that nice sequence of FSH, then estrogen, then LH, and progesterone. But the cycle charting is your roadmap. And in 90 days, you're going to gain this body literacy. And after 4 cycles, you'll be able to do the ultrasound series as well. And you're going to be really accurate. And you'll be teaching your doctor on how it's done. And you're going to be your advocate because you know what your body's doing. And that's the power of cycle charting and working with Lisa. So there. How's that, Lisa?
Well said.
Yeah, no, that's great. I think it's hard though, because I would never want to say it's going to be easy, because you're right. Once you chart your cycle for several months and you have your data and you know when you're ovulating and you go to your doctor and they say, come back on cycle day 21. And you're like, well, I don't ovulate until da-da-da-da-da. Oh, did you Dr. Google and da-da-da? So it's never easy, but I do feel just like what you said, Nora, it's really important to get that base of understanding. And then you start demanding the care that you need. And if your practitioner, unfortunately, is not, playing ball, then you can kind of move on to the next one. Maybe we can talk a little bit then. So in your practice, in my practice, because I'm not a naturopathic doctor, I can't prescribe anything. So there's no prescriptions coming from me. There's a lot of collective work working in conjunction with a person's practitioner and those types of things. But with that said, in my practice, I do a lot of kind of those lifestyle pieces that people really underestimate to lengthen the luteal phase. But in your practice, there are a lot of tools that you have at your disposal. So one of the topics that I'd love to get into is the pharmaceuticals, because it's really, I find this whole conversation to be very interesting. So as you can imagine, from my side of things, there's a lot of people, a lot of women, a lot of practitioners of different kinds who are kind of really anti-medication and, they don't really they want to stay away from it completely. And then we have the medical system where it's like all medication all the time. And what I think is so interesting is the very specific way that the two of you use different pharmaceuticals in your practice in a way that's a lot different to the medical system, a lot less, I don't want to use the word harmful, but a lot less harsh maybe, and a lot more in tune with the cycle. So why don't I just let you take it from there?
think probably the easiest thing that I'm very blessed to have access to is bioidentical progesterone, because it can save a life, right? We've been able to save. We had was it Nora? Was it due to the antibiotics or progesterone? We had a student who took our course, and a registered naturopath, who was telling Nora in real time, I am saving a pregnancy as we speak, because we're properly timing the prescription. Or she's helping her advocate.
Yeah, she was in Winnipeg, and we say on our website, we offer one-on-one phone support after the course to clarify course content. So we've had several hundred students take our course, and I think we've had maybe 14 call us. And so I can count them on 2.5 hands. And I love it, because I find on the phone, you can clarify a gazillion questions quickly. And then I always hear the good news. By the way, I'm advocating for my patient right now, and she's getting cultures done, and the antibiotics have stopped the contractions. And for me, I'm just jumping out of my seat. So we're saving a little life in Winnipeg as we speak. And so it's very, very exciting. Yeah. And so again, it's the concept is minimum dose targeted to the cycle, targeted to the individual woman. And so as Jessica was saying, naturopathic doctors have access to compounded progesterone in Ontario. And I think oral progesterone as well is available for BC naturopathic doctors. Is that right, Jessica?
Correct.
Yeah. Yep. So, but it's really not every province in Canada. And so the job of a naturopathic doctor in the other provinces and in several states is to collaborate with medical doctors. And unfortunately, there's some very strange negative conclusions being made about progesterone in the States, because so many studies have been poorly designed, not based on the woman's individual chart. It's based on the biomarker of last menstrual period. And so they're going to test for progesterone on day 21, and they're going to start prescribing progesterone, let's say on cycle day 17 or 18, which is not necessarily in sync with 80% of women. And so you're going to have a destructive effect on women's health if you time the progesterone at the wrong time.
Yeah, I've seen all kinds of prescriptions. Yeah, day 12 to 24, day 14 to 28. It's so arbitrary.
It's very arbitrary. Yeah. And so in the Creighton world, it's very precise. You want to give progesterone from peak +3 to peak +12. And that's in sync with the woman's cycle. And you want to sort of overlap the natural crescendo decrescendo of progesterone production during that luteal phase, which is peak +3 to peak +12. And if you bring it in too early or too late, you're going to either hinder the corpus luteum or hinder the follicle. Because if you bring it in too soon, the follicle's not going to rupture. If you bring it in too late, you're going to artificially prolong a corpus luteum action, and then it's going to be action, reaction. You're going to sort of deregulate the next cycle. So it's very harmful. And that's what's not being concluded in the studies. What's being concluded is that progesterone doesn't work. Well, it does work if you time it based on ovulation or on peak day. Yeah. So
it's getting quite a bit of bad press with respect to PMS, because the thought is it's going to elevate even more that metabolite of progesterone, allopregnanolone, which can make the mood symptoms of PMS or PMDD even worse. But I have to say, clinically, when we get the right dosing and the right prescribing, peak +3 to peak +12, as far as some of the more physical symptoms like the bloating and the spotting, it works, so I think more studies, better designed studies for sure. But the chart again becomes such a beautiful, informative way to manage your prescriptions. Again, minimal effective dosing. Yeah.
Well, I mean, ironically, today I had a class with my fam practitioners, and one of the case studies is a client who was administered progesterone. There's many situations where progesterone is administered, obviously. One of them is the challenge for women who are not cycling at all. So in her case, she was post-pill and she wasn't really having a cycle. And it was quite soon after, maybe within 3-4 months of her coming off. And the doctor gave her progesterone and told her to take it on whatever day 14 or whatever it was. And so she had these charts where there was 3 or 4 charts back to back where there was no ovulation, because she was taking this progesterone on whatever day they told her. There was no ovulation. And so until she actually stopped taking it, we weren't even able to see if she was ovulating and when it was happening in the cycle and all those kinds of things. And certainly I've seen women who are trying to conceive and their doctor tells them to take it on a certain day, a doctor's word is very powerful. Mm-hmm. And so if the doctor tells them to take it on this day, that's the day they're taking it.
Right.
And so I've certainly seen cycles where, they're trying and they think they've ovulated because the progesterone raises their temperature, but they didn't. And so they kind of lose that cycle. So certainly for me, this is a big topic in my work. And I don't know if you've experienced this, but I certainly have seen the resistance of clients to wait 2 days, wait 3 days to start taking it just so that we can confirm that you've ovulated, because they're so scared something bad is going to happen if they don't take it right away. So maybe, I don't know if you want to talk about that, but certainly this is how I see it kind of practically playing out very consistently. It's a huge pet peeve of mine, to be honest with you.
Yeah, I have a patient who's PCOS patient. I think we've ruled out hypothalamic amenorrhea, but again, she's never known a cycle without it being forced withdrawal bleed because her doctor has just kept her on cyclical progesterone this whole time. So we're not fixing anything here at all. The whole goal is to actually let's actually help you ovulate on your own. And we're never going to know if we're doing that right unless we see what your body wants to do without that help, right? So I think there's definitely a place and time for progesterone.
Well, and I have a question about progesterone, because obviously it's it does work. It when you time it correctly, when you dose it correctly, there's no question that it does work, I think, for most people. Sometimes the question that I have about progesterone, though, is that if a person is not making enough, then, from my perspective, there's a reason why. So how do you find that in your practice?
This is Nora's favorite $1 million question.
All right, made her day. Yes, I'll just finish my thought, because my question then, from a practitioner perspective, you're giving this client progesterone to help their PMS and their symptoms go away. So are they just going to take it forever, or what happens there?
Good question.
No, I don't believe in taking anything forever. No, the goal of any prescription is to restore health. But absolutely, why is progesterone low is such an important question to address. So just as naturopathic doctors, if you step back, if the patient has eczema or psoriasis or arthritis or rheumatoid arthritis or high blood pressure or diabetes or osteoporosis, all of these conditions in their one way or another will hinder the production of progesterone. So it's one thing to give progesterone. It's sort of, that's the Band-Aid, and it's a good Band-Aid, but you really want to step back and restore bone metabolism and cardiovascular health and blood sugar balance. And so it's a question of looking at the whole person. So absolutely. My geeky little hobby is cyclic AMP, and cyclic AMP is low in all those conditions I just listed previously. And it's cyclic AMP, if it's not optimum, will hinder progesterone production as well. So think of like in histamine, like allergies. Allergies will also hinder progesterone production. So you really want to build up the person inside out and restore their health, and then the progesterone can thrive. And ideally, you can get off the progesterone. So it's absolutely, you want a whole person approach to.
Yeah. And as a naturopath, I used to think that I was actually really against progesterone, any kind of bioidentical hormones previously to me starting to use them, because I thought this is not naturopathic at all. We're not treating the cause. We're just plopping in some exogenous hormone. I have to say, though, now that I've been using it, to see it restore a woman's health and fertility, help her maintain a pregnancy, it's safe. Like, why not? So I think the important thing is we're using it in context of other things to support the why. So if you have inflammation, if you have eczema, psoriasis, you're not just forgetting about that and throwing in progesterone for the fun of it. You have to treat the cause. Look at the terrain, treat the microbiome dysfunction, treat the inflammation, work on the adrenals, make sure the thyroid is working well, because you need T3 to make progesterone. You need progesterone to make T3. It works both ways, right? And then think, is there a place for a little bit of minimum effective dosing just to get them to where they need to be health-wise, right? Because, for me, in my fertility work, mental health is right up there, my list of priorities to support. And so the longer the journey, the more complex the journey, the more intervention, the worse off they are from a mental health standpoint. So if we can restore that ahead of time and help them to avoid more invasive procedures like IUI or IVF, then it's a win for me, and progesterone is safe. So that's where I'm at now. I've evolved.
It's time, ladies. Time to take your fertility awareness knowledge and confidence to the next level. Just popping into today's episode to invite you to join us for the next round of Fertility Awareness Mastery Live. My 10-week group coaching program is designed to help you unlock the secrets of your menstrual cycle. Fertility Awareness Mastery teaches you everything you need to know about using fertility awareness cycle tracking to achieve your intentions. Whether you're currently trying to get pregnant, avoiding pregnancy, or planning to conceive in the future, we've got you covered. This program goes deep. Get to the root of your period problems, hormone imbalances, fertility challenges, and so much more. Early bird registration is now open, but only for a limited time. Head over to fertilityfriday.com/fam to register today. That's fertilityfriday.com/FAM. Now let's go ahead and jump back into today's episode. Yeah, I think, from many different perspectives, because of course I've thought about this from all kinds of perspectives. But when your option is miscarriage or when your option is IVF, a lot of these subtle, timed, very nuanced approaches to that kind of perfect combination of medicine and the menstrual cycle, it really does achieve, in many cases, the result you're looking for with minimal potential side effects and things like that compared to the full dosing of certain types of medications in the medical system. So I think it is really important. And of course, that's why I am not personally a NAPRO practitioner, but certainly I speak about NAPRO and I've interviewed NAPRO practitioners, because that approach is kind of like the best option, like the best version of medicine as far as I'm concerned, where it's allopathic, yes. So know that, but it also works alongside the menstrual cycle. And of course, you take a bit of a different approach because you're naturopathic doctor. So you're taking more of a holistic approach. So I think it's just really nice, actually, for clients to have so many different options to really achieve what they're looking for.
Well, I did the NAPRO training in 2010. I loved it because it introduced drugs in a whole new light. And we're speaking at a conference in April to naturopathic doctors, and we're going to cover low dose naltrexone. And we're also going to cover progesterone and thyroid, HRT. I think how they all tie in is that on the ovary itself, there are receptors for progesterone, obviously, because it makes the corpus luteum, but also there are receptors for opioids and thyroid. So in that little ovary, you need your opioid or endorphin system to work, you need your thyroid system to work, and you need your progesterone system to work. And that for me is amazing. And I'm sure there are more receptors on the ovary we just don't know about, but it's really amazing how health and fertility have so many interrelationships. And so NAPRO sort of introduced that concept to me, is that there are many avenues in the body to restore hormone balance. So
yeah, you say it so much better than the way I say it. I say there's many ways to skin a cat, and you said it in a way that's just so much better. But
it's crazy how complex and interrelated everything is. It's just crazy. But anyway, it's beautiful, and it sort of makes sense. When you think about it, there are marijuana receptors in the uterus, for heaven's sakes. It's crazy how complicated the body is.
I can never say that word, but it's like the cannabinoid receptors.
Yeah.
I just say marijuana. So.
Field. Yeah.
Well, I was looking at some research on the cannabinoid receptors. So
system.
Maybe I'm just saying that word just because it's a little bit of a ridiculous word to say. So, one of the questions that I get a lot, obviously, in the work when you're kind of mucus focused, is around mucus production.
Love that.
So I thought I would just throw that out there because we spoke the conversation about progesterone, and that really addresses a lot of the questions around the cycle length and lengthening the luteal phase and things like that. And I think it's really good to know that you do have those types of options depending on your practitioner and what they're willing to do. But when it comes to mucus production, so this is kind of, again, one of the most common questions. If you look at my DMs, it's like, where's my mucus? So maybe share a little bit about some of the approaches that you have with clients who are concerned that their mucus production is less than that 5 days that you mentioned.
Nora, you want to go, or do you want me to?
Yeah, we can. We'll do it together. But I'll start. Just think of no mucus is no follicle.
Yeah.
So your follicle isn't growing, because if you don't have a growing follicle, you don't have growing levels of estrogen in the blood. And that can't turn on the cervical crypts in the cervix to produce the white flow.
Yeah.
So why isn't the follicle growing? And stress. Jessica has a lot of interest in PTSD and stress. So I'll take it away, Jessica. That's one.
Yeah, I mean, I've seen that in many, many patients where, we don't even talk about mucus. We're just addressing their anxiety, we're addressing their sleep deprivation, we're addressing their high cortisol levels. And the minute we do, boom. The minute they start to feel joy or actually activate their pleasure centers, boom, cervical mucus starts to come back. And not just arousal fluid, like actual slippery, stretchy from the crypts. Mucus is starting to appear. So it's lovely in that sense. And, nutritionally, we think about things like B6 and flax seeds and things like that. Also, what's interesting is like looking at more of the thyroid piece is that oftentimes, hypothyroidism is going to interfere with follicle growth and also estrogen production. And so you could have a patient with, let's call it subclinical hypothyroidism. So on paper, they look fine, but they have all the markers, right? Their eyebrows are thinning, their hair is thinning, they're always freezing, their face, like their skin feels dry, it might be constipated, difficulty, losing weight. They're exhausted all the time. This person is not, either there's a receptor problem or there's a conversion to activated T3 hormone problem. Something's not right in there. You might see it in their basal body temperatures are too low, both pre and post ovulation, right? And so that can also contribute to dysfunctional white flow and also dysfunctional bleeding as well. Too much bleeding sometimes. So those are just some of the things I'm thinking about. And I think, a lot of patients they're already aware, right? So we do get a lot of patients who come in and that's all they want to work on. But we have to take a step back. If their diet is really inflamed, if their psoriasis is out of control and it's using up all their reserves to just manage that, and the body isn't going to give it to things that it doesn't need to for survival, right? So that's kind of big picture thinking. I get it, but that's how I kind of look at it. You got to clean all that up first, and then you start to see a real change in their cycle.
Mm-hmm. Yeah, because there's this huge connection. Obviously, you need the estrogen to make the mucus. What I see a lot as well are potentially the damaged crypt situations to kind of add to that problem, where you have potentially history of the surgeries because of the HPV. I worked with a lot of people who come off of contraceptives, and then the contraceptives themselves can have a suppressive effect. So I think it's helpful to have this kind of a big picture. So when you ask that question of like, why don't I have any mucus? I mean, the answer just took about 5 minutes to go through potential reasons why. So it might seem like this a really simple issue. Sometimes it can just be like, we really need to dig to figure out why. Like, is it structural? Is it hormonal? Is it stress related? Is there an underlying condition? So,
right. And I appreciate that. And I definitely feel like I need to do more research there, but certainly like patients who've come off LEAP procedures and they're noticing, at least in the cycles immediately following that procedure, definitely they're wondering about, is that going to permanently damage my cervical mucus? So luckily, the cervical crypts go all the way up the cervix. So as long as some of them upstream are preserved, I think over time, like there is cell turnover, right? So over time, the hope is that with good nutrition, things that support cellular health, like folic acid, dark leafy greens, get them thinking about that, and hopefully that can help to recover that mechanical injury down the road.
Well, and another question I get all the time, very popular topic, is seed cycling. And so I'd love to have you share your perspective and experience with that. I mean, from my perspective, I think it's so interesting because there are some practitioners that are like anti-seed cycling. You're like, it's pumpkin seeds. Like,
yeah, right.
Problem.
Is there an RCT trial double-blind study on?
I know, like, what could go wrong here? So definitely in the ether, like in the kind of socials, there's certainly different perspectives on this, as I'm sure you've found. Some practitioners are very much kind of against it. And then I fall somewhere in the middle because I do think that there are a lot of benefits. But at the same time, I think a lot of the clients that I see are facing some bigger problems. And so they might need more than just the seed cycling protocol. But I'd be interested to hear what you found, because you shared that you've seen some really interesting research about it, which is fascinating that there is research about it.
The research primarily is on flax seeds, probably for their lignans and their mildly phytoestrogenic capacity. But there was an interesting study that I came across that showed they didn't test other seeds, but looking at flax seeds, and I would maybe extrapolate that. Maybe hemp hearts would work too, maybe chia seeds, because they're all kind of in the same family, right? Is that it could regulate cycle length. And I have seen that to be true clinically. A patient with 25-day cycles, they get on regular flax seeds. Now they're having more like 28-day cycles. Not that that's the goal, but it's more to optimize the event, which ovulation. We just want them ovulating well. We want that follicle growing. So whatever it is that can support them. I just like it for the fact that everybody can probably use more fiber. Everybody can probably have better bowel movements. And it's like one less pill they have to take that they're willing to do. They feel like they're in control of their bodies. They're using it in conjunction with their cycle tracking. It's motivating for them. And if they enjoy it, I say, why not? There's no harm. Absolutely. Yeah. And I've seen some patients, even amenorrheic patients, have their cycles return with seed cycling. So don't knock it. Like, it might be gentle, but even gentle things can be very powerful, in my opinion.
Mm-hmm. Nora, did you have any
and then
thoughts?
And also in terms of pre-peak and post-peak seeds, the rule of thumb is that pre-peak you want to be eating the omega-3 seeds, so like flax and pumpkin. And then post-peak you want to start at peak +3 or peak +2, the omega-6 seeds like sesame and sunflower. And if you sync it up that way, then you're augmenting estrogen balance in the first half of the cycle and progesterone balance in the second half of the cycle. But you don't want to do day 1 to 14 omega-3 seeds and day 15 to 28 omega-6 seeds, because that's what's being taught, and we don't agree.
And I have to say, pre-cycle awareness training with Nora, I was guilty of that too. Sort of a standard protocol that we're given right out of school, and now it's changed.
Yeah.
Well, that's really helpful. So for all of the seed cyclers who are tuning in, so I'll just kind of reiterate. Basically, Nora and Jessica are suggesting that instead of doing it based on days of your cycle, so calendar method, we're suggesting to actually pay attention to your cycle. So before you ovulate, as Nora shared, it was the flaxseed and the pumpkin seeds.
And pumpkin, omega-3s, yeah.
And then after you have confirmed ovulation, so so peak +3, and then of course I teach symptothermal, so the third high temp, the evening of the third high temp, or both. And so then you would take, you said the omega-6 seeds. So that was the sunflower seeds and the sesame seeds. Is that right?
That's right.
Okay. So we've got it now.
Progesterogenic. Yeah.
And then hemp contains all the fats, so you can enjoy those any day. And also chia, I believe, is omega-3. And that's good for pre-peak. So there's a lot of options out there.
Well, and chia seeds are excellent for that. Again, for that gentle fiber that helps you go. So lots of positive things there. Well, so you and Jessica have some exciting things coming up. So before we go today, why don't you share a little bit about your conference that's coming up and how the listeners can find out more about that. Also, Fertility CE and where they can get a hold of you too.
Thanks. So we're going to be guest speakers at this Canadian conference, and it's called Collaborative Education. It's a company that has done an amazing job of delivering continuing education to healthcare providers all over North America, but they really feature a lot of naturopathic doctors, which is nice. So we're one of the keynote speakers, and that's the weekend of April 23 and 24. And the website is collaborativeeducation.com. And we're very excited. We'll be talking about progesterone, thyroid, and low-dose naltrexone, which is a opioid receptor antagonist, which in turn will help the body make more endorphins. And that's one way of restoring ovulation. And that's our talk at the end of April. And then, Jessica, you want to talk about our 6-hour course?
Yeah, our 6-hour course is sort of evergreened now. And we've gotten, we've taught to almost 300 practitioners across the world, mainly North America. And not just naturopathic doctors, nurse practitioners, pharmacists. We've had a couple midwives and great response. Doctors. Yeah, and some MDs. So we have accreditation for all naturopathic doctors across North America, and also accreditation with the American Academy of Family Physicians. So if you are a nurse practitioner, you can get credits for our course too. It's a full restorative course with the highlight being cycle charting. And then from that, being able to time properly your blood tests, your ultrasounds, and then timing your treatments, whether it's botanicals, whether it's nutrients. We talk about things like endometriosis, PMS, PCOS. So it's a full gamut. And we have a lot of fun with it. And so you can check us out at fertilityce.com, or on Instagram, we're at fertility.ce.
Awesome. Well, I will have all those links for the listeners in the show notes. And so, of course, thank you as always for being here. It's always fun to chat with the two of you. You have a wealth of information. And again, I think it's wonderful for women to just learn about all these different options. I think so many women go to their doctors and they think that's it. Like they think that that's all that there is available. The good news is that there is more. So the doctor should be part of your team, but there's more room, more chairs at the boardroom table, and we should fill them with Nora and Jessica. And
I want to say last thing, like I'm living proof. Like I was the post-pill amenorrhea PCOS case. And this is why I'm here, is because I went through literally every pharmaceutical option there was to offer. And nothing helped me until I worked with my naturopathic student at the time. She was a clinician, to recover my cycle and help me have my two beautiful children. So I've lived it and it works. So all the work that you're doing, Lisa, is paving the way for all these women. So thank you.
Well, thank you so much. Well, I will talk to you both very soon.
Thank you so much for this wonderful chance to chat.
Always great to talk to you, Lisa.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode over at fertilityfriday.com/411. I hope that you enjoyed today's episode with Nora Pope and Dr. Jessica Liu. It was a treat to have them on the show, and of course, they are a wealth of information. And the topics that they're touching on, it's interesting because I first had Nora Pope on the show many years ago. And ironically, one of the big topics that we discussed, which is the use of progesterone in terms of when it's appropriate to use in the cycle, seems to have become a bigger kind of challenge since our first episode, if you will. So it's certainly one of my biggest pet peeves when working with clients, because, in my experience, most practitioners to this day who prescribe progesterone do not provide sufficient instructions as to when is the appropriate time to take it. And I think that one of the reasons is because, generally speaking, progesterone doesn't necessarily have a lot of side effects. It has a lot of benefits. And I feel like compared to other medications, it's certainly considered to be low risk. And from a health perspective, I suppose it is kind of low risk. But when you're trying to conceive or trying to sort out your menstrual cycle health, when progesterone is given at the wrong time, it can do a lot of things that you're not wanting to happen. Particularly for my conception clients, when they follow their doctor's instructions and take the progesterone on a specific day of the cycle instead of waiting until they've confirmed ovulation, actually confirmed it, and not just with an ovulation predictor strip, to actually confirm after the fact with temperature or progesterone test or an ultrasound or something. Basal body temperature tends to be the easiest way to confirm ovulation at home. But when they're taking it before they've confirmed, I've seen it many times on the chart where it will prevent ovulation, and then that cycle is unusable. So again, that's one of my biggest pet peeves about progesterone. And then a smaller pet peeve about progesterone is that now that it's become a lot more common, I think it's a lot more mainstream, although many doctors still wouldn't necessarily prescribe it unless you ask for it. It's a lot more common now, and I think a lot more people are talking about it. It does seem to be the go-to fix-it strategy, which then can replace the important step from a functional perspective of actually looking at why she's not making enough. So I think because low progesterone is one of the most common issues women face when they start charting their cycles, they see short luteal phases, spotting, PMS symptoms, all these kinds of things. I think that the progesterone is a super easy fix to get all of that under control artificially right off the bat. It's very effective. It obviously helps to prevent miscarriage, and it's a very important tool to have in the tool belt. But ultimately, most women are able to produce sufficient progesterone when they take away some of the factors that are preventing them from making enough. So it's an interesting conversation. And I think if I had my way, there would just be more nuance. We would just have more of a nuanced conversation about it, including looking at the whole woman, some of the reasons why she's not producing it, not jumping to the conclusion that she's not capable of producing it, and having a strategy for, are we just going to be on it forever, or are we going to be on it for a period of time? Are we going to reevaluate this? Like, what's this going to look like? But most importantly, when in the cycle is the most appropriate time to take it? How can we do it and time it with the cycle so that it's not going to be suppressing ovulation and causing other problems that you did not anticipate? So, short rant for the day, but I feel that whenever the topic of progesterone comes up, I jump in and share some of those things, especially for the newer listeners who may not have heard the rant before. And for those of you who are struggling with progesterone-related issues and wondering if supplemental hormonal progesterone replacement therapy is right for you, I would encourage you to head over to episode 383. So you can scroll down if you're listening in your podcast player, or you can go to the page fertilityfriday.com/383. In that episode, I shared a number of effective strategies that do actually work to improve progesterone in most women, outside of some of the other challenges that can cause, like endocrine issues and things like that. But the most common reasons for low progesterone I discussed in that episode, and strategies that I effectively use with my clients to help them to lengthen their luteal phase and reduce some of those progesterone related issues, like the spotting and the kind of moderate to severe PMS and things like that. So again, episode 383. And I would suggest to try some of those things first, before jumping to the progesterone, unless it's a more dire situation related to fertility challenges and things like that. So with that said, I hope you have a wonderful weekend, whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting.